Greetings and welcome to the GENMF Primary Care Leadership Program Colloquium on Patient Education. The moderator for this colloquium is Dr. Dana Marshall, Associate Professor of Surgery at Meharry Medical College.
Communication between healthcare workers and the community is critical to the maintenance of health in that community. Communication is most effective when those involved understand each other at every level, and research in the area of patient education provides the opportunity for both the provider and the recipient to occupy common ground. The first report of a research paper in the area of patient education was in 1946, and it was a TB questionnaire. Although education about TB has become less of a need, the second of two papers on patient education published in the 1940s was on the topic of diabetes. PubMed reveals 76,281 papers on patient education since 1946, of which 8,468 address the topic of diabetes. Three of our patient education scholars did research this summer on diabetes. Two of our scholars worked on pediatric asthma, which first showed up in the patient education literature in 1982 and accounts for 415 patient education papers historically. One of our scholars worked on obesity, for which there are 1,664 papers starting in 1974, and one worked on education in regards to advanced directives, totaling 315 papers starting in 1990. Clearly, there is much to be done still in the area of patient education, and our 2013 scholars worked on some of the most critical.
Now we'll hear from our PCLP scholars who will each discuss their projects.
Hello, my name is Bethany Baker, and I'm a senior nursing student at Middle Tennessee State University. I was placed in Nashville, Tennessee at the Matthew Walker Comprehensive Health Center. My project is titled Community Matters, Diabetic Program Evaluation and Survey through Community Outreach via Telenursing. The purpose of this project was basically to increase adherence to the Dial Down Diabetes program and to assess the effectiveness of the program. I completed the project by making follow-up telephone calls to people who joined the Dial Down Diabetes program from May of 2012 to May of 2013. The patients were asked to participate in a survey. I made the survey using SurveyMonkey, and it asked questions based on overall demographics, nutrition, physical fitness, medication, motivation and support, and program participation. I found that most participants were African American females between the age of 41 and 50 with an A1C greater than 9. The majority, about 82% that is, feel like the program motivates them to make lifestyle changes. This showed true in regards to nutrition and exercise. 65% of participants claimed to eat healthier and 45% exercise more frequently. However, 40% of patients admit to not taking their medication as prescribed, and 60% feel the program does not affect how they take their medication at all. The main reason for participants not taking their medication as prescribed was basically just not following instructions. The patients understood how to take their medication, but chose not to do so. There were varying reasons for this. Some patients did not like the side effects of their medication, and some felt like they could make their medication last longer by cutting the pills in half. The survey also showed that almost 78% of participants did not have a good knowledge of the Dial Down Diabetes program and what it has to offer, such as educational workshop dates and times. Over half of the participants, that is 54%, also wanted to make an appointment but had yet to do so. Their names were taken and they were called the following day. Appointments were made for all of those who wanted one. Overall, I recommend that patients be better educated on the side effects of medications, ways to decrease the side effects, and why it is important to adhere to the medication instructions. Being that almost 73% of patients were prescribed metformin, a simple handout on metformin could be useful to give to the patients taking this drug. Also, there really needs to be more marketing of the Dial Down Diabetes program. It's a great resource for this community, and it has potential to help several people in the Middle Tennessee area manage their diabetes. I recommend for every diabetic patient that comes to the clinic, they need to be given a handout that lists the dates and times of the educational workshops for the year, as well as all of the services offered. Finally, because of telenursing, over half of the patients called came back to the clinic. I recommend that nurses make telephone calls to patients who need to come back for follow-up appointments. It is a quick and easy way to bring patients back in, build a relationship, and maintain preventative care that is proactive versus reactive. Reflecting on this project, I realized that there needed to be a Spanish translator available because a lot of patients I called did not speak English. It would make the results more accurate to include Spanish-speaking patients. Also, I think there needs to be more research done on why patients are not taking their medication as prescribed. All in all, though, I think this served as a good general survey to pinpoint what does and what doesn't work. In reflection of my experience at Matthew Walker, I found myself deeply moved by the mission of the center. I've decided to go to graduate school to become a nurse practitioner that provides primary care. I feel this experience reinforced my desire to go into primary care and to help those in need. I'm very thankful to National Medical Fellowship and GE for this incredible opportunity they provided me and for the huge impact that it has had on my future in the healthcare field. I hope y'all enjoyed my presentation, and thank you so much for your time.
Good afternoon. My name is Ashley Cole. I'm a third-year physician assistant student at Mississippi College. As a GE Primary Care Leadership Program scholar, I was assigned to Jackson, Mississippi at Jackson Hines Comprehensive Health Center. Nationally, diabetes affects about 7.5 to 10% of the population, according to the 2012 America's Health Rankings Annual Report. In Mississippi, however, according to that same report, diabetes affects between 12 and 16% of the population, ranking Mississippi as number 50 in the area of diabetes. Therefore, I chose to focus my independent project on the evaluation and enhancement of diabetes education within the Jackson Hines Comprehensive Health facilities. My goal was to assess the current forms of diabetic education offered at Jackson Hines Comprehensive Health Center and develop a diabetic-friendly grocery list that would act as a companion to the already existing literature. I used a survey to assess the patient satisfaction in diabetic education in a sampling of 17 Jackson Hines Comprehensive Health Center diabetic patients. I modeled the diabetic-friendly grocery list after the recommendations of American Diabetes Association sample shopping list and assessed its cost and usefulness by compiling a booklet of diabetic-friendly recipes and pricing the ingredients at local grocery stores. While the majority of the patients surveyed were satisfied or somewhat satisfied in the diabetic education they had received at Jackson Hines, there were some deficits in the areas surveyed, particularly in the areas dealing with the purchasing of diabetic appropriate foods. These findings were further reflected in the discussions surrounding the distribution of the grocery list. When presenting the grocery list to the patients, I explained to them that the list could be used to build a diet of appropriate ingredients, and if found to be useful, the list could be reused. All the patients surveyed expressed the need of this type of list in their everyday lives. Based on these studies, my final recommendations to Jackson Hines were to continue to build the already existing curriculum through frequent evaluation and analysis of the patient's understanding. Education should start with the basics, by using a tool like the Diabetic Friendly Grocery List to show patients what they can do today to start on a path toward meeting their goals in optimal diabetic management. My time spent at Jackson Hines left me with a new understanding of community health centers, great lessons in clinical treatment, and lifelong friends. I am truly grateful to GE, the National Medical Fellowship Scholar Programs, and the faculty and staff of Jackson Hines Comprehensive for an amazing summer. Thank you.
Hello, my name is Whitney Jolitz. I am a fourth-year medical student at Pacific Northwest University College of Osteopathic Medicine. This summer, I was placed in Nashville, Tennessee at Matthew Walker Comprehensive Health Center. The title of my project is An Adult Plan for a Healthy Weight, a clinic-based intervention for patient weight loss. The objective of my project was to develop a focused weight loss plan that was created as a collaboration between both the provider or student and the patient, with both giving input, and to see if a focused plan like this would be effective for patient weight loss and or changes in lifestyle habits. Patients with a BMI of 30 or above were selected from Matthew Walker Internal Medicine and Family Medicine Clinic or United Health Services health screenings at Parkwood and McFerrin Community Health Centers in Nashville, Tennessee. The first part of my project was having patients complete an adult plan for a healthy weight form. The front page of the form includes an area to list the patient's current weight, their current BMI, and the diagram to show what BMI category they fall in. There's also a section that includes the patient's goal weight and the date they would like to reach that in. On the back page, there's a list of nutritional and physical activity goals that the patient can choose from, or there's also an area where they can individually write goals in. The patient's goal weight and their nutritional and physical activity goals were to be realistic and healthy, and that was something I was trying to oversee while I was filling out the form with patients. The second part of the project was to follow up with these patients. In total, I had 15 patients fill out the form, and 3 were lost to follow up. All patients were contacted over the phone and were followed weekly until the end of the 5th week of the externship. The following questions were asked the patients during follow-up. Are they keeping track of their weight at home, and if so, what is their current weight? Have they been able to meet their physical activity and nutritional goals? Do they feel like they have support at home for their goals? Do they feel ready to add any new goals? Do they feel that follow-up with the clinic is helping them meet their goals? The 2 most commonly selected nutritional goals were to eat fresh, frozen, or canned fruits or vegetables with the aim of 5 to 9 servings a day. Patients also chose to eat more meals at home instead of eating out, and if I do eat out, I will bring home half the entree. The 2 most commonly selected physical activity goals were to find a workout partner to hold me responsible for my physical activity goals and to take daily walks. 100% of patients found follow-up to be helpful and for them trying to keep their nutritional and physical activity goals, and over 90% of them felt like they had support at home. In summary, I feel that an adult plan for a healthy weight form is an inexpensive and personalized weight loss resource that community health centers and physician clinics could use to help patients lose weight. The form does take, between 3 to 5 minutes to fill out with the patient, but you could have a nurse or someone else fill it out with the patient. With the rising prevalence of obesity I think it'll be important for us providers in the healthcare field to find possible solutions and help, to help these patients who are battling this disease. Thank you.
Hola, hello. My name is Zulma Perez Estrella, and I'm a second-year medical student at the University of Kansas Medical Center. And this summer, as part of the 2013 GE National Medical Fellowship Primary Care Leadership Program, I was placed at Eisner Pediatric and Family Medical Center and the USC Eisner Family Medicine Clinic in Los Angeles, California. The title of my work is Advanced Directive Education for Patients. See, as part of a federal requirement, all healthcare institutions receiving Medicare and Medicaid funding, such as the USC Eisner Family Medicine Clinic, are required to provide written information about life-sustaining treatments or advanced directives to all of their adult patients. However, these forms are rarely ever completed, so I was asked by my faculty mentors and site advisors to create a curricula that will promote the understanding and the use of advanced directives among the patient population. So I began my project by first interviewing 17 USC Eisner Family Medicine Clinic patients. The purpose was to assess their knowledge about and their sentiments of advanced directives and advanced directive education. I also reviewed and studied 5 different advanced directives that were being used throughout the clinic and neighboring sites. In this process, I found that many of the advanced directives were above a 12th grade reading level and full of legal jargon that can be intimidating to patients. Based on the interviews and research, I then chose to work with one, the Institute of Healthcare Advancement Advanced Directive. And this was an advanced directive that was at a lower literacy level, contained pictures, colors, and was easier to comprehend. Based on the advanced directive chosen in the interviews, I then created a 1-hour workshop in Spanish and English to provide knowledge about the end-of-life treatment options and to teach how to utilize and complete an advanced directive form. 3 workshops were conducted with 14 total participants. 2 of the workshops were in Spanish and 1 was in English. At the end of the workshop, patient satisfaction surveys were distributed, were studied, and then I incorporated this feedback back into the workshop. So my key findings were that prior to this workshop, 100% of the patients did not know how healthcare decisions would be made if they were too sick to verbalize their wishes themselves. And in addition, 100% did not know about advanced directives, although they had been given one in the past when they first registered as a patient. Nonetheless, after taking part of our workshop, 100% of the patients said that the information received was important and was helpful, and 86 identified as very probable to complete the advanced directive form and return it to their provider. It's important to note that these workshops require very little resources and were very well received by patient participants. Furthermore, our goal was met. Patients' knowledge and comfort surrounding advanced directives and end-of-life sustaining treatments, and these conversations improved. The majority of the participants who took part in our workshop also took the initiative to become a resource for their friends and family because they took additional advanced directives for these family members and friends. My recommendations to my site are the following. 1 is to standardize the use of one advanced directive among all of the Eisner Pediatric Family Medical Center sites. 2 is to continue providing educational workshops on advanced directives. The next recommendation comes from my experience talking to these providers and patients at Eisner, and based on my research, it seems that it's a problem that's experienced commonly among the field of medicine, and that is the comfort of having end-of-life discussions with patients. So from my site, I believe that there's a need to clarify and improve the role of physicians and family medicine residents surrounding advanced directives, and then improve this patient-provider advanced directive discussion. Lastly, there's a need to upgrade the electronic health record template to include advanced directive tracking because currently the system does not have a set location to where to place or to note that advanced directives were provided or that a form was completed or even that a form was given to a patient. So overall, my experience this summer was a great one. I was pushed outside my comfort level to work on an issue that I had very little knowledge about, but that I now realize is essential to know, especially since I will be pursuing a career in primary care. My experience with my mentors, my advisor, and the site location was one that not only surrounded the work around my topic of advanced directives, but also was about learning about leadership in primary care and in community clinics firsthand. I was very lucky to have been placed at Eisner, and I'm grateful for Eisner Pediatric Family Medical Center, the USC Eisner Family Medicine Clinic, and the General Electric National Medical Fellows Primary Care Leadership Program for the wonderful experience. Muchas gracias.
Hello, my name is Gwen Sunkel, and I'm a senior family nurse practitioner student at Indiana University, Purdue University, Indianapolis. This summer, I participated in the GE National Medical Fellowship's Primary Care Leadership Program, and I was placed in Nashville, Tennessee at United Neighborhood Health Services. My independent project focused on preventing asthma attacks in the pediatric population at UNHS. So some background information. Existing research shows that targeted education programs regarding trigger avoidance is effective in reducing acute asthma exacerbations or asthma attacks in persons with low health literacy. Home visits and patient interviews revealed that the patient population seen at United Neighborhood Health Services is exposed to a number of potential triggers. Many reside in public housing and report problems with poor ventilation, leaking plumbing and windows, mold, dust, and rodent and cockroach infestations. High pollen counts and air pollution in the Davidson County area can cause exacerbations that have a seasonal component as well. Children were often found to spend time with caregivers who smoke, which is one of the most common asthma triggers. UNHS providers were also interviewed, and they indicated that they frequently saw patients exhibiting a knowledge deficit in regard to usage of their medication. They were often mixing up their short-acting beta-2 agonist or rescue inhalers with their long-acting inhaled medications that are intended to prevent symptoms. This results in poor disease control and more frequent asthma attacks. Patients also exhibited a knowledge deficit regarding how and when to use a spacer, which leads them to receive an inadequate dosage of their inhaled medications. Providers requested an information video on controlling asthma symptoms that could be easily accessed during office visits. This would allow patients to view the video while the provider completes any necessary documentation related to the visits. So a video was developed and placed on YouTube, so it could be accessed on a smartphone or a tablet computer during a visit. Patients could also then access the video at home by searching the term UNH asthma on YouTube. So this 5-minute educational video suitable for persons with low health literacy was distributed to providers and will also be shown periodically on the closed circuit television in clinic waiting rooms. The video was also translated into Spanish to meet the educational needs of Nashville's Spanish-speaking population. I then developed labels that were designed to help assist patients in differentiating between their inhalers. One label was to go on the short-acting beta-2 agonist inhaler that stated that this was a rescue inhaler to be used only during an asthma attack, while another label was developed for controller medications that said this medication should be taken every day according to providers' instructions and was not for use during an acute asthma exacerbation. So these labels were also given to providers so that they could make them available to patients who demonstrated difficulty with medication compliance. To assess the effectiveness of these interventions, I suggest that United Neighborhood Health Services mine data from the next-gen electronic health record regarding the number of asthma-related visits and requests for rescue inhaler refills. If a patient's asthma is well controlled, they should not have to use their rescue inhaler as often, so a decrease in the number of refill requests for short-acting beta-2 agonist inhalers would indicate asthma that is controlled. And patients whose asthma is well controlled miss fewer days of work and school and are at a lower risk for complications associated with frequent acute asthma exacerbations such as lung infections and lung remodeling. So by implementing these education strategies, UNH staff and providers can reduce healthcare costs while helping patients achieve positive health outcomes. I want to thank General Electric and the National Medical Fellowship for the opportunity to participate in this educational program. Thank you very much.
Hi everyone, my name is Bin Vu, and I am a current second year medical student at William Carey University College of Osteopathic Medicine. I am in the DO program here in Hattiesburg, Mississippi, and my city placement was in San Antonio, Texas at community care health centers. My project is about trying to assess parental knowledge of pediatric asthma triggers and try to see how much they know about asthma and the triggers, because there are some triggers out there that they're not aware of, and they probably tend to think try to blame it on like the common triggers such as the common cold, seasonal allergies, or dust and mites. So we just want to know if that's the case and if there needs to be some kind of education program that can be implemented to help intervene and reduce the asthma attack morbidities and mortalities. So my overall objective is to assess parents' knowledge about asthma triggers, then use the extrapolated data gathered from my surveys to focus on certain intervention, education, and prevention efforts to reduce asthma morbidities. My method was that I created a survey, and the criteria is that they have to be a pediatric patient of 18 years of age or younger and who has a history of asthma or wheeze, or if they come in for asthma or wheeze. Then I would get parental consent and ask them if they would want to do the survey and give them the survey. On the survey, it has a total of about 11 to 12 questions. There were no personal patient information requested except for basic demographic questions such as gender, age, and zip code, just for personal information and for the community care health centers information and logistics. From the surveys, the key findings that I found was that most asthma symptoms tend to occur in the home environment, and parents identified the triggers that they believe that cause their child's asthma symptoms is due to weather changes, cold and flu, and dust. And however, most of those that surveyed listed that they used air freshener products and fabric softener sheets in their household. What they fail to realize is that these are common household items that can cause asthma triggers, which tend to be lesser known, and the chemicals in these chemicals, like air fresheners and fabric softeners, can exacerbate asthma symptoms, which leads parents to think that, oh, it's just dust or the weather is changing. But these are very serious household items that parents are not aware of, and if we can educate or have some kind of intervention program to where nurses or social workers can visit the household and see what could be taken away or reduced to modify their child's asthma disease. There was a program that was started in Boston. They call it the Boston Asthma Health Initiative, where they actually went in and did an intervention in the household to help reduce asthma attacks and exacerbations, and it really showed a lot of reduction in ER visits, parent loss of work time, child's loss of school time, and etc. So it's really helpful if there could be some kind of intervention program implemented throughout the U.S. So what I can recommend is that health centers, clinics can give out handouts and or educate parents or guardians about lesser known asthma triggers that could exacerbate their child's symptoms, and some kind of community asthma education and prevention program coupled with home visits can raise awareness about lesser known asthma triggers. But that's what I found from my project. But overall, I really enjoyed the summer program. It gave me a lot of experiences which I cannot get inside the classroom. I was exposed to community medicine and its aspect of treating patients on a more global scale, and it's just unbelievable experience that I would not trade for anything in the world. And if given the opportunity, I would do it again, and I was thinking about doing it for a fourth year because this was an opportunity of a lifetime that I am grateful for, and I thank you, Primary Care Leadership Program and the GE Foundation and the National Medical Fellowships for giving me this opportunity to learn and grow and solidify my decision to go into primary care, especially pediatrics, which I really want to do. I think that's it.
The summer projects spanned a range of conditions and healthcare needs, but there are some common themes that go along with trying to execute patient education programs in community health centers. The projects included diabetes education to prevent and control disease, education to encourage healthy living and weight loss, advanced directives and identifying the best education tools and understanding why people don't complete an advanced directive, and pediatric asthma, proper control, and what are triggers that exist in the environment. I identified some common themes between these projects, including the following. Providing educational support is important, but even people who understand their specific disease or healthcare issue do not always execute the necessary steps for the best outcome. Secondly, best possible outcomes are often limited by factors other than education, as environments and fundamentals of the individual's life that are limited by lack of resources must also change. And this includes the very important lack of phones for follow-up. Recruitment of individuals to participate in education programs is difficult and may require research to determine the best way to approach people to participate. Based on the topics and the themes, I came up with 3 questions for discussion, and I'm really interested in hearing some more insights from the scholars on these questions. The first one is, what percentage of eligible health clinic patients participated in your summer project, and how well do you think those who participated reflect the community health clinic's patient population as a whole? Second, what are the most effective ways of recruiting people to participate in educational programs at community health clinics? Third, in all of the projects, there appeared to be a substantial number of individuals who understood their instructions but did not follow them for maximum health benefits. Many of you reported financial barriers to success, for example, pill splitting, having to buy food that is perceived as being more expensive or may be more expensive, living in environmentally challenging housing. There were barriers of self-confidence, perhaps like the person who indicated that I don't want to set a goal because it's just something for me to fail at. Or there's a transcendent barrier to success that spans community health centers to even the most wealthy, which is people don't want to think about end-of-life decisions, and therefore they're failing to complete an advanced directive. Once the information is out there from your education efforts, how will you address these other barriers?